This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.
So welcome to our educational session today. We're going to be talking about the expanding treatment options in ER-positive disease and the rapidly emerging role of SERDs, SERMs, and SERCAs. I'm Erica Hamilton. I lead the breast cancer research program at Sarah Cannon in Nashville, Tennessee, and I'm joined by two fabulous colleagues. Ditya, we'll hand it over to you to introduce yourself next.
Thank you, Erica. Hello, everyone. I'm Aditya Bardia, breast medical oncologist at Massachusetts General Hospital, Boston. Looking forward to the discussion today.
And Surat?
Yeah, Surat Chandralapati. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Thanks so much for being here. So, recognizing gaps and unmet needs in ER-positive disease, I think we're all learning this. Certainly, even prior to San Antonio in 2021, we saw the results of Veronica really showing in the post-AI CDK4/6 setting that fulvestrant is not performing as well as we would typically expect. So certainly, endocrine therapy and CDK4/6 resistance does develop, and post-CDK4/6, the benefit from therapies and how patients do is more poor than we have classically thought of. Certainly over on the right, you see emerging agents, and it comes as a word salad: SERMs, SERDs, PROTACs, CERANs, and SERCAs, and we're going to talk about many of these classes today. So let's go into current standards of care and guideline recommendations. This is a very busy slide, but this is the NCCN guidelines, essentially really just summarizing that first-line therapy is endocrine therapy in combination with a CDK4/6 inhibitor. There are certain situations that we may use fulvestrant instead of aromatase inhibitors, but really aromatase inhibitors and CDK4/6 is the standard. In the second line, there's a variety of options. Certainly fulvestrant, we have the PI3 inhibitor alpelisib approved. We can fall back on endocrine therapy with everolimus as well. And so we're going to get into some of the details as we go through this today. So I'm going to turn the next session over to Surat for us.
So what we thought would be useful in sort of thinking about these different endocrine therapies was to begin, I think, with a case. And so even though we're not going to, closely track this case, I think it's useful for us to keep it in mind. So this case is a 54-year-old woman who originally was diagnosed with stage 2 ER/PR positive, HER2 negative breast cancer about 4 years ago, and got standard of care adjuvant AC and Taxol, and then was placed on an aromatase inhibitor. Eventually developed right hip pain, and imaging showed lytic bone lesions, and was a biopsy of the liver revealed, again, PR positive, HER2 negative breast cancer. There was next generation sequencing done, and that showed activating PIK3CA mutation. She started therapy on fulvestrant with palbociclib and developed progression after about 2 years on therapy. And so as we think about this patient, just keep it in mind, what are sort of some of the options, and why might we be thinking about these different options, whether it's fulvestrant plus alpelisib, exemestane plus everolimus, capecitabine, or clinical trials of some of the new novel ER targeting agents. All right, so let's think a little bit about these different endocrine therapies. First, by way of background, how is it that endocrine therapies work? And endocrine therapies work based around the fact that estrogen is a lineage driver for both normal mammary cells as well as breast cancer cells. And where does estrogen come from? Estrogen comes from both ovarian as well as non-ovarian production of androgens that are converted to estrogen. And as shown in this diagram, that estrogen then binds to the estrogen receptor in the breast cancer cell, and then that activated unit then leads to transcription. And so then how do the drugs work? Well, the drugs can either work by preventing the body from making estrogen, and those are the aromatase inhibitors, as shown in panel B, or by interfering with the estrogen receptor, directly binding the estrogen receptor and preventing estradiol from binding. And so both SERMs and SERDs and even PROTACs, all of these molecules work by binding the same place that estrogen would normally bind. The effects of that, however, can be different based on the actual drug. So SERMs, like tamoxifen or others, bind in a way that still leads to ER doing something. It may be mostly inactive, but it may be active in some tissues. And so that's why we get things like uterine hyperplasia with drugs like tamoxifen. With the SERDs, like fulvestrant, we get really a complete inactivation of the receptor. And so while it's still there, it goes to the nucleus and it is ultimately in a sort of inactive place and is eventually degraded. And then these more recent drugs like PROTACs actually lead to a stimulated degradation of the receptor. And so you lose estrogen receptor because not only do you inactivate it through the binding of the drug, but that drug tethers in what's called an E3 ligase that then leads to complete degradation of the receptor. So these are all different ways of ultimately inactivating the estrogen receptor itself. So there are a lot of these different ER-targeted agents. Those are classes, and then these are the different ones that are in current phase 1 or 2 testing. There are actually more than are on this list. I don't think that we need to necessarily go through all of these different agents specifically, although we will give examples of several of them that are in different phases of development as we go through today. The point is, I think all of them are really geared towards retargeting ER in a different way than the aromatase inhibitor was targeting estrogen production. And why might we do that? Well, we've had great success in breast oncology over the years by just retargeting the estrogen receptor. So we originally used a drug like tamoxifen and then found that an aromatase inhibitor worked after that. So the cancer has some addiction to estrogen receptor signaling, and when it develops resistance to these drugs, it often does so in a way that reactivates ER. And one of the principal ways that we see that clinically is through these estrogen receptor mutations. And so many of us have done next generation sequencing on our patients and seen these mutations that come up. What are these mutations and what are their implications for drugs like SERDs? Well, again, SERDs work through stimulating an inactive receptor that ultimately gets degraded. And fulvestrant, while it is a potent ER degrader and SERD, in vitro, when we give it in vivo, as most of us know, it's a intramuscular injection. It's given monthly. And that sort of bioavailability may be a limitation for the drug over the long haul. And so there have been the development of oral versions of these drugs that we think maintain a much higher level and so lead to more complete inhibition of the receptor. And that's especially important with these ER mutations because they're more active. They're constitutively active. And so having more drug available might be critical in order to completely inhibit these mutant receptors. On this slide here, we're just showing that we know that these mutant receptors are constitutively active, and that clinically drugs like aromatase inhibitors really don't do very much against the mutant receptor. Why? Because these mutant receptors don't need estrogen to be active. So blocking estrogen production does very little, whereas ER antagonists like fulvestrant can have some efficacy. Now, I want to caution by saying it isn't the only way that we see endocrine resistance occur. It is not the only genomic alteration that is seen in our patients who have metastatic breast cancer and who've progressed on, whose cancer has progressed on a hormone therapy. We do see other alterations as well. And while we're not going to go through all of them, I just want to say that there are many classes, if you will, of resistance mutations, many of which are actually acquired in the metastatic setting. And that's one of the critical points as we think about next generation sequencing to figure out endocrine resistance. Many of these alterations, like ESR1, activating mutations in Her2 or NF1, as well as inactivating mutations in NF1, sorry, as well as others within the MAP kinase pathway. These are alterations that are increasingly seen in prevalence in the metastatic setting compared to the primary setting. In many cases, they may be acquired over time. That means that as we think about doing next generation sequencing to profile what mutations might be present in our patients and what treatment options might be available, we really want to think about the most contemporary biopsy to look for these alterations. If we go back to the primary that was resected 4 years ago, we're likely going to miss any ESR1 mutations. We may be missing other important alterations as well, and some of these are targetable and have implications for the therapies that we choose. So just to very quickly say what specific ESR1 mutations might we be seeing when we pull up that genomic report. Shown here is a cartoon diagram of the ESR1 gene, and the major mutations that we're looking for that cause aromatase inhibitors not to work are these mutations in the part of the gene, part of the protein that binds to estradiol, of course. And so these are all in the ligand binding domain. And these are the 4 or 5 most common mutations in 536, 7, and 8, and E380, as well as S463. These are all mutations that have been shown in the lab and in the clinic to be associated with resistance to aromatase inhibitors. And you know, one of the things that has been sort of considered is how can we act upon these mutations quicker if we find them? How can we sort of translate what I've described about how the mutations cause resistance to aromatase inhibitors and try to target them then with a drug like fulvestrant? And this was one way, and this was realized in a clinical trial, was recently reported with the PADO-1 trial, where they had patients who were treated with standard of care aromatase inhibitor plus palbociclib in first-line metastatic breast cancer, and tracked patients using cell-free DNA to look for the mutation profile, specifically looking for ESR1 mutations, and then randomized patients at the point at which they might have acquired an ESR1 mutation to either continue on with therapy or to switch to fulvestrant to try to target that, that ESR1 mutation. And shown here is the patients who were randomized, and then on the next slide I think we have really what are the outcomes of these patients in whom there was a ESR1 mutation detected, and then they were either switched or not. And you can see here many patients who had clearance of that mutation as a consequence of going on to fulvestrant. And so what these data really tell us is the potential for targeting ESR1 mutations. Whether or not we should be switching patients on as they are on AI plus palbociclib, I think is still to be determined, but I think that it at least provides us with a biologic and potentially clinical translation that targeting these mutations with a drug that's actually going to bind the mutant receptor has real potential to change the trajectory of the disease. So again, we have a number of potential agents that are currently in clinical trial testing, shown here, some further along than others. What are these SERDs? For that, I think we'll turn it back over to you, Erica.
Great. So Aditya, I'm going to have you cover the next section on some of the data from San Antonio.
Sounds great. So let's move on to SERDs. We'll start with the Emerald trial. This was presented at the San Antonio Breast Cancer Symposium in 2021, a randomized phase 3 trial looking at an oral SERD versus standard of care endocrine therapy. This is the first phase 3 trial with an oral SERD, looking at the agent in the second, third line ER-positive metastatic breast cancer setting. So it was for patients who are postmenopausal or men who've received 1 to 2 lines of endocrine therapy and had measurable disease or bone-only disease that was evaluable. The trial had 2 inclusion criteria that are important to mention. The first being that the trial required patients to have disease progression on prior CDK4/6 inhibitor, consistent with current guidelines where CDK4/6 inhibitors are recommended as the first line therapy. And the second was that the trial allowed 1 line of prior chemo for metastatic disease. Patients were randomized to receive the oral SERD elacestrant at 400 milligrams once daily versus physician's choice of endocrine therapy, which could be fulvestrant, which is what the majority of patients received, versus an aromatase inhibitor. In terms of stats, the trial had more than 90% power to detect a hazard ratio of 0.667 in all patients, and in ESR1 mutant subgroup, more than 80% power to detect a hazard ratio of 0.61. The trial had 2 co-primary endpoints, the first being progression-free survival in all patients, and the second being progression-free survival in patients with ESR1 mutations. In terms of baseline demographics and characteristics, more than 450 patients were randomized to either receive elacestrant or standard of care endocrine therapy. 239 received elacestrant, 238 standard of care. As expected from a randomized phase 3 trial, the demographics were well balanced between the 2 arms, age, gender, ECOG performance status. It should be noted that majority of the patients in this trial had visceral metastases, about 70% of patients, and about 20-25% had received 1 prior line of chemotherapy. So this was a patient population that had aggressive biology given the visceral metastases and use of chemotherapy. So it's not surprising that majority of patients had received prior adjuvant therapy, and the percentage of patients with bone-only disease was small. In terms of the results, progression-free survival by independent review committee, the trial met its primary endpoint. Patients who received elacestrant was a standard of care. The hazard ratio was 0.69, so 30% reduction in risk of progression or death in patients with ER-positive, HER2 negative metastatic breast cancer. And this was statistically significant. If you look at the median PFS, was 1.9 months with standard therapy. So pretty much at the time of first restaging, about half of the patients had disease progression. And this was slightly better with elacestrant, 2.79 months. And in terms of patients with ESR1 mutation, as was reviewed by Sarat earlier, one of the mechanisms of resistance to endocrine therapy is the development of ESR1 mutations. And the presence of ESR1 mutations indicate 2 things. The first is that the tumor is estrogen independent, but still dependent on ER. So agents that bind to ER would work in this setting. And second, it also signals that in the endocrine resistant setting, you're likely dealing with a tumor that's still dependent on the ER pathway. As was nicely reviewed by Sarat, in the setting of endocrine resistance, second, third line setting, you can have tumors that are still dependent on the ER pathway, but you can also have tumors that are independent of estrogen and the ER pathway. And endocrine therapy is unlikely going to work if the tumor is completely independent of the ER pathway. But SERDs could potentially work in tumors that are dependent on the ER pathway, and ESR1 is kind of a surrogate marker that signals that this tumor, despite this being in the second, third line setting, could still be dependent on the ER pathway. So in this setting, looking at elacestrant versus fulvestrant, you could see an improvement in progression-free survival, 45% reduction in risk of progression or death, hazard ratio of 0.54, so almost doubling of progression-free survival. But again, if you look at the absolute median progression-free survival, it was 1.8 versus 3.7, so approximately 2 versus 4 months. So while there was a doubling of survival, the median progression-free survival with elacestrant was about 4 months, indicating that we clearly need to do better in this setting. Now, if you look at the curves carefully, you see that there's a drop in the first few months. And so this is an important figure because it really captures the benefit of this novel agent versus standard of care. So approximately half of the patients have disease progression in the first 2 months with standard of care. And you also see a drop in elacestrant arm early on. But then after that, you start seeing a separation of curves. And to me, this is important because the initial drop likely signals this endocrine resistant population or population where endocrine therapy, particularly as monotherapy, is unlikely going to work. But then after that, you see a separation, and that likely is a subgroup where patients still have endocrine sensitive disease. So if you're evaluating two agents that are endocrine therapy, you can see a separation. So in terms of landmark analysis at say 6 months, patients who received elacestrant had a higher PFS rate at 6 months, 34.3%. So 1 in 3 patients versus 20.4% with standard of care therapy. And similarly with among patients with ESR1 mutations, you see a higher PFS rate at 6 months, 40.8% versus 19.1%. And if we extend that further to 1 year or 12 months, again, you see that patients who received elacestrant had a higher PFS rate at 12 months, 22.3% versus 9.4% with standard therapy, and similarly for ESR1 mutations as well. So the key is to identify patients that still have endocrine sensitive disease, because in that setting, you can see a clear benefit with a novel agent that is likely better than standard of care therapy. In terms of directly comparing elacestrant versus fulvestrant, about 70% of patients in the trial received fulvestrant. So comparing an oral SERD versus an intramuscular SERD, again, you see similar results. So hazard ratio of 0.68 in overall population and 0.50 or doubling of progression-free survival in patients with ESR1 mutations. Again, the 2 points. First, that the absolute median progression-free survival is still around 4 months, so a need to do better in that setting. And the second point, that you again see this drop initially in the curves and then you see a separation. So clinically need to identify patients who likely have completely endocrine resistant disease versus endocrine sensitive disease. In terms of subgroups, essentially all the subgroups derive benefit with elacestrant versus standard of care endocrine therapy, including number of prior lines, measurable disease, presence of visceral metastases, prior treatment with fulvestrant. The subgroup that potentially did not derive benefit was patients who had received prior chemotherapy, but I would caution that the numbers are small, so we need additional validation related to these results. And finally, in terms of overall survival, there was a trend towards improvement in overall survival with elacestrant versus standard of care endocrine therapy. For the overall population, the hazard ratio was 0.75, And in patients with ESR1 mutation, the hazard ratio was 0.59 with a p-value of 0.03. But these are interim analyses. The final analyses with mature data would occur approximately a year from now, so would likely be available in late 2022 or early 2023. In terms of safety, majority of the patients had at least one treatment emergent adverse event. The incidence of grade 3 or 4 treatment-related adverse event was low in single digits. And so it's not surprising that AEs leading to discontinuation were infrequent in both arms, 6.3% with elacestrant and 4.4% with standard of care endocrine therapy. And there were no treatment-related deaths in either of the groups. And then finally, in terms of type of AEs, the number one side effect seen with elacestrant was nausea, 35%, so 1 out of 3 patients had nausea. The incidence of grade 3-4 nausea was 2.5% with elacestrant. Other AEs like arthralgias or hot flashes are pretty much similar between elacestrant and standard of care endocrine therapy. And because fulvestrant is given as a shot, it was associated with pain that is associated with IM shots, which was not seen with the other oral therapies. So with that, give it back to Erica for discussion.
Yeah, thank you so much. I think, Sarat, you definitely set the stage about the estrogen receptor and kind of how these different drugs may work and lead to some differences, and certainly very excited to see the first phase 3 data from the oral SERD. Sarat, I may pose a question to you to start. You know, obviously PI3 kinase mutations are actionable now with fulvestrant and alpelisib approved. That's kind of in the second line setting, so to speak. When do you routinely profile patients? And do you think ESR1 is actionable now? Or are you?
Yeah, great questions, because you know we get these reports and they may come from different points in time, and we have to decide in real time what are we going to do for our patients. So I think that right now, as you laid out with the NCCN guidelines, I mean, we can use PIK3CA mutations to guide us towards a alpelisib. And the presence of an ESR1 mutation would tell us we really wouldn't want to combine that with an aromatase inhibitor. The approval is with fulvestrant in any event, but I do think that as we start thinking about where are these, what are we going to combine our targeted agents with, whether it's a PI3K inhibitors or everolimus, I think we're going to want to use that ESR1 mutation to say, should we actually give an aromatase inhibitor? And I think that the main example where I'm using it, for instance, is if I'm giving a patient everolimus, I could give them either an aromatase inhibitor or fulvestrant. And if there's an ESR1 mutation, we've shown with retrospective data, but also I think biologically, we just know that fulvestrant is going to be the better partner for that scenario. So that's one instance where we're using it. Of course, we're excited to see whether the ESR1 mutations will be informative for some of the new SERDs like elacestrant, and whether approvals will be based around that, we don't know. But I think that the use of this information certainly should be shifting us away from aromatase inhibitors towards SERDs when we know it's present.
Yeah, absolutely. That's very similar to how I use it in clinical practice. Aditya, I think you really kind of brought up one of the issues that I thought of when I saw the curves as well for the first time with the oral SERD is, the percentage of patients that really just looked like they weren't endocrine sensitive. And when I looked on the tail, with oral SERD, there was about 30% of patients where if they were on at 8 months, they remained on at 24 months. So there's clearly this population that's getting great benefit. This is a lofty ask, but clearly this goes above, just checking that they're still ER/PR positive. Any ideas of how we may be able to select those patients that truly are endocrine sensitive and are going to benefit from the oral SERD?
Yeah, absolutely. Great question. And I think that would be the next phase of research, trying to identify what is this subgroup that had this rapid drop versus patients who remained on the drug for prolonged period of time. In the Emerald trial, we plan on looking at biomarkers such as activation of the PI3 kinase, MAP kinase pathway, the things that Sarat mentioned in his talk that could contribute towards endocrine resistance. And then also clinical pathological features like patients with bone mets only versus patients with hepatic mets, also patients who derive benefit from a CDK4/6 inhibitor. So all of these patients had prior CDK4/6. Can we look at the duration of prior CDK4/6 inhibitor as just a marker of endocrine sensitivity? So those are the things we would look at. At this time, outside of ER, PR, and I guess ESR1 mutation, I'm not aware of other pathological characteristics to look at, but certainly an area of ongoing research.
Great, thanks so much. So Sarat, I'm going to turn it back over to you to discuss some of the other SERDs.
Yeah, and I think I want to begin by saying it can feel indeed like a word salad. Well, you've gone through one SERD. What do we need to know about these other SERDs? But remember, some of these small and subtle differences in ER antagonists can lead to important differences in terms of efficacy and in terms of toxicities. We don't know until we really put these into the clinic. You know, you wouldn't be able to tell a difference between, say, fulvestrant and some of these other drugs when we looked in vitro in the lab. But the proof came when we looked clinically at how these worked. And so we're going to go through a couple of the SERDs that have looked promising in early phase data. The first one we'll talk about is amstonestrant. And this is the AMERA study, which is a large phase 1/2 study. And in this data set that was reported at San Antonio, the combination of amstonestrant with palbociclib was reported. And again, as Aditya alluded to, I think we are increasingly going to be interested in how these new oral ER antagonists perform in combination with the targeted kinase inhibitors. So here, looking at the combination and dose escalation in Part C with palbociclib, and then in Part D in dose expansion at the recommended for phase 2 dosing, which in this case was 200 milligrams of amstonestrant. Many of these patients were all postmenopausal with advanced breast cancer and had no prior CDK4/6 inhibitor therapy in Part D in the expansion group. And shown here is the activity that was seen with amstonestrant plus palbociclib from 35 patients who were in the response evaluable population. You can see 34% of patients with a partial response and 74% overall with clinical benefit. And the waterfall plot shows the extent of responses from this population. Again, this being a combination of palbociclib together with amstonestrant. And it notably is that this activity was seen in patients who had ESR1 mutations and patients who even had prior chemotherapy in the advanced setting. So, good data that you can combine this together with a CDK4 inhibitor and see activity. And then in terms of toxicity, it was quite comparable to the toxicities seen with other endocrine partners with a CDK4 inhibitor. Again, the number one toxicity related to amstonestrant being nausea in about 18% of patients and no grade 3 or 4 nausea, as well as fatigue. And then some of these, of course, being related as well to potentially palbociclib. There are, of course, now multiple additional studies with amstonestrant that are ongoing and ought to be reporting in the next year, including a study in the first-line setting, AMERA-5. in combination with palbociclib. In addition to amcenestrant, giredestrant, or GAC 9545, was also studied both as monotherapy and in combination with palbociclib in the advanced setting, and reported by Nick Turner and colleagues at San Antonio. You can see here the swimmer's plot from the monotherapy and then the combination. And again, really compelling clinical benefit rates, 81% in the combination with palbociclib and 54% for monotherapy. And what was reported in addition was some really interesting preclinical work, biomarker work that looked at patients who had biopsies, paired biopsies, pre-treatment and on treatment, and looking at was ER signaling inhibited and was ER ultimately degraded, and what was the implication of ESR1 mutations on this. And you can see from these diagrams that there is a real strong downregulation of ER expression by immunohistochemistry. There was also data to show downregulation of ER signaling. So really showing in these patients, a large percentage of whom had ESR1 mutations, that the drug was able to block ER signaling and degrade the ER receptor despite the presence of ESR1 mutations. And in many patients, in looking using cell-free DNA, there was multiple ESR1 mutations observed. So again, there are multiple other SERDs in different stages of development with large number of patients who have been treated. And so it'll be really interesting to see as these move into phase 3, similar to Emerald, how well they perform compared to fulvestrant, how well they combine with other CDK or other targeted agents. How much can we, leverage this better, more potent inhibition of ER, this greater capacity for eliminating the receptor, together with trying to target whatever that other oncogenic signal is, whether that may distill down to CDK4 or the PI3K mTOR pathway.
Thanks so much, Surad. I think that was excellent. Certainly I think the potential for oral SERDs are in the post-CDK setting, even in combination in first line, and perhaps even in the early stage settings as well. I guess I'll open a question up to both of you. What do you think the differentiating factors are going to be with the oral SERDs? Certainly there's over 10, maybe close to a dozen in development. Do you think it's going to be efficacy? Do you think it's going to be tolerability? And which side effects stand out to you?
It's a tough question. I think that there are a couple of things. One thing that is sort of underrated is going to be, I think, in these combinations is going to be PK and the potential for interactions and whether you are getting the full effect of the combination partner, or if there's any attenuation of, say, CDK4/6 inhibition or PI3 kinase inhibition with your hormone agent, then that could be a challenge. One of the things that we observed was preclinically is that many of these pathways they synergize, and so if you inhibit PI3K, for instance, you induce the estrogen receptor to even higher levels. And one of the implications is that it makes fulvestrant, again, a drug that's not quite at its full sort of potency in patients, not quite as good. And so trying to get the maximal ER inhibition becomes all the more important, especially if there's an ESR1 mutation present. So how these drugs are able to accommodate those kinds of sort of interactions between the pathways is going to be important. Are we fully inhibiting both parts of that we're intending to?
Yeah, I think that's a really important perspective. I I think that side effects are going to matter a little bit too. I think it's very hard to compare kind of apples to apples across some of these earlier phase 1 studies with differing populations, et cetera. But you know, what we saw with CDK4/6 inhibitors is it was kind of the side effects that patients could feel that they cared about, right? They didn't so much care about asymptomatic neutropenia. So I think that some of those differences may sort out a little bit as well. So let's move on to the next section that I'm going to earn my keep and discuss here. So these are the SERCAs, the PROTACs, and the SERMs, and hopefully you'll get a little bit of an understanding about how these compounds are different and how they may fit in with SERDs and be a little bit different and play a different role for us here. So SERCA is H3B6545. You can see clinical trials that are ongoing, single agent as well as in combination with palbociclib. The CERAN, or complete estrogen receptor antagonist, is OP-1250, and that's certainly ongoing in clinical trials as well. And then Arvinas, the proteolysis targeting chimera, which is another fancy way really to say a degrader like a SERD as well, ARV-471, that is also ongoing and is in combination with palbociclib as well as a dose expansion currently. So let's dive in with H3B6545. So this is the SERCA, so selective estrogen receptor covalent antagonist. So this was the phase 1/2 study, and you can see 72 patients were treated here. Partial responses in about 17% of patients, although I would really argue that it's not necessarily our response rate we care most about in metastatic ER-positive disease. It's really the benefit patients are getting, so progression-free survival or clinical benefit rate. And if we do look down here to the conservative definition of clinical benefit rate, complete response, partial response, as well as stable disease of at least 23 weeks, that's 40% here. So we also sorted this out for some of our other correlative science work that we could do. So those tumors that also had progesterone receptor positivity, you see potentially a little bit better activity there. And I would argue that that's really because estrogen and progesterone should go hand in hand. And if we see PR loss, potentially that's an indicator to us that that tumor isn't as dependent on the estrogen axis. And then over on the right, according to ESR1 mutation status, certainly some of these clonal mutations also have the ability to kind of predict a little bit better benefit. And again, ESR1 mutation is really a resistance mechanism that grows out due to the cell's dependence on estrogen. So another way to really select these tumors that very much care about estrogen. And so this is a phase 2 study of 6545 in advanced breast cancer. You can see some of the inclusion criteria as well as the exclusion criteria. No limit on prior hormonal therapies or CDK4/6 inhibitors. Certainly looking at some of these ESR1 mutations as well and not allowing more than one chemotherapy. And so if we look across key subgroups with the H3B6545 compound, you certainly see activity whether patients have already received fulvestrant, which really was the majority of patients on trial. We see activity even when patients had already received a novel SERD or a SERM across chemotherapy and number of regimens. So here's the progression-free survival. You can see the median months here is 3.8. And if we go over on the right and select for some of these ESR1 mutations, we again see this lengthen not different than the data that Aditya presented. So with some of the clonal mutations, upwards of maybe 5 months or even 7 months. And then here's the waterfall plot, which I think just gives us a good idea of the kind of benefit patients were receiving. So you really saw a little bit more than half having tumor shrinkage, and some of them, you know, quite significant shrinkage with H3B. And then this is the phase 1b study. Again, it's the SERCA in combination with palbociclib, and a little bit tricky to follow this, but really talking about how to escalate the H3B versus the palbociclib in case we see more issues with neutropenia. And here is safety. Overall, this compound really is tolerated quite well. We see a little bit of anemia across with the CDK4/6, which is not surprising. Certainly, we see leukopenia, which we would expect with CDK4/6, and not much thrombocytopenia. We do also have the side effect of bradycardia, which the H3B compound happens in about half of patients, and the vast majority of these patients, really all but just a couple, is grade 1 asymptomatic. Grade 2 is symptomatic but no intervention needed. And we really don't see a large QT signal with H3B either. And so what did we see when we combined with palbociclib? So you can see over on the left the different cohorts here with the median treatment duration in weeks along the bottom. And over on the right, the waterfall curve really showing benefit with 2 patients at the 300 milligrams with palbociclib at 100 milligrams really doing quite well there. We do think that potentially we get a little bit higher exposure of the CDK4/6 when given in combination with H3B, so 100 milligrams may be plenty. And here is the PK. Again, no significant PK interaction really. And so let's switch gears. This is data presented at San Antonio about ARV-471, which is the PROTAC or proteolysis targeting chimera. So it's a different twist on a degrader. Over on the left, you see the swim lane plot, and I know this is probably very small on your screen, but there's asterisks over on the side for prior CDK4/6, which you'll note everyone had already seen prior CDK4/6. About 80% of patients had seen fulvestrant, and then we had 10% of patients that had already seen an investigational oral SERD, which I think is really fascinating if we track some of these responses. The clinical benefit rate in this population was 40% in the 47 evaluable patients, and we certainly did not see really differing responses based on whether patients had already seen investigational SERD. So I think this can be important information when we think about sequencing or what drugs may have activity after our other drugs that are coming. Waterfall plot over on the right also showing that we saw activity really across broad doses. So it does not appear that we need to be at the highest doses to get activity. And in fact, we did not see an MTD. And so into the expansion, we're carrying forward both 200 milligrams as well as 500 milligrams to figure out where we really need to be here. And so what did we see with safety with ARV-471? Really looked quite encouraging to my eyes. Nausea in about 30% of patients, and this was all grade 1 nausea except for 1 patient. So I think that was reassuring to me. And fatigue, I thought, also looked pretty good at only about 20% any grade fatigue, and again, this really being mild. So in summary, this is the first drug of its class presented here as a PROTAC. We saw activity in a phase 1 really heavily pretreated patient population with a median of 4 priors, including some with oral SERD, with pretty minimal toxicity, compares pretty well from a GI standpoint as well as a fatigue standpoint. And so again, the VERITAC cohort's enrolling 2 different doses in expansion. There's still the combination with palbociclib ongoing, and there are phase 3 studies planned as well. So Surat and Aditya, I think not only do we have SERDs, we also have a host of other word salad compounds. Do you see a role for multiple of these in sequence, do you think?
And a good question. I think it will be important to understand the differences, particularly related to common mechanisms of resistance. One of the things that was interesting with H3B was this observation that even among ESR1 mutations, Y537S mutations, in that subgroup, the median PFS was pretty high. It's a small subgroup, but could there be differences even based on the type of ESR1 mutations? And I think these nuances probably will differentiate these different agents. So based on the mechanism of resistance, one agent might be better than the other. And obviously the side effect profile.
Surat, any thoughts on that?
Yeah, I agree. I think that one of the interesting things if we think about another disease, prostate cancer, we get a lot of mutations there that are the kinds that turn a mutant receptor, that turns a drug into an activator. Now, we don't see those with the aromatase inhibitor resistance ESR1 mutations. These are mainly just on receptors that our antagonists work. But we haven't really profiled patients after they've gotten ER antagonists of different flavors like this. And so it is certainly possible that the mechanism of resistance to one mutation may be something that sensitizes it to one of these other agents. So it'll be really interesting to look at mutational profiles after patients have gotten, say, an oral SERD or a SERCA or a PROTAC even.
Yeah, absolutely. I completely agree with that. There was actually a fantastic talk at San Antonio by Dr. McDonnell out of Duke, really showing, how very small changes in these molecules can make a huge impact on really the function of the estrogen receptor and the shape and conformation that it takes. And so, he really argued that, these compounds, although they may seem very similar, really can make a big difference. And it's probably not going to be across everybody. There's not going to be one that's best for every single patient, but different ones may be best for different patients, and kind of a challenge of whether we're going to get smart enough to kind of figure that out and be able to stratify these patients based on some of the differences. So I'm going to turn it back over to Aditya, and I think we're going to go back to our case and kind of revisit that in light of some of the things we talked about and learned so far.
Yes, coming back to the patient, coming back to the case. So 50-year-old female with history of stage 2 ER-positive, HER2-negative breast cancer, received standard therapy, then unfortunately had disease recurrence in the bone, commonly seen in the ER-positive setting. Also hepatic mets, biopsy revealed ER-positive HER2-negative disease. Patient also had NGS testing of the tissue, which revealed a PIK3CA mutation. So first-line therapy, fulvestrant plus palbociclib was started, which is very reasonable in this setting. Worked for a couple of years, and then the patient had disease progression. So now the question is what to choose next for this patient. Fulvestrant alpelisib, exemestane everolimus, capecitabine, a clinical trial, or something else. I'll just make a couple of points and would love to hear from the panel as well. I think so far the management has been exactly as we would want. So this patient had disease progression on adjuvant AI. So in the first line setting, you would start a different endocrine agent, and that being fulvestrant. And while the patient had PIK3CA mutation, at this time in general, we would consider a CDK4/6 inhibitor, because that does work for even PIK3CA mutant cancers. So that was appropriate as well. But now the question is what to consider for this patient. Maybe I'll start with Erica. Erica, what would you consider in this setting for this patient?
Yeah, I think that was a great summary of the case. I mean, in an ideal scenario, to use alpelisib, we would love it if the patient hadn't had fulvestrant, but that's not this patient's particular reality since they relapsed on that adjuvant aromatase inhibitor. I probably would still use fulvestrant alpelisib here. They have the PI3 kinase mutation. This is targeted specifically for that mutation. In earlier PI3 studies, there was single agent activity, and even in the light of the progression on fulvestrant, you think kind of using those compounds together really can provide some benefit. So I would be thinking about fulvestrant alpelisib for this patient. Surat, what would you do?
Yeah, I think the same. The only sort of consideration would be if additional testing post the CDK4 inhibitor revealed a PTEN alteration as the mechanism of resistance to palbociclib. I might, in that case, veer towards the everolimus or capecitabine options. One other thing I would just want to sort of bring out is, we talked about how there were other sort of forms of endocrine resistance besides ESR1 mutations. And while these don't constitute the sort of 35–40%, these small subgroups represent large populations of patients for whom there actually may be some interesting trial options. And so I just want to point a couple of those out because we should all be on the lookout for them. HER2 mutations are seen in this population, and both HER2 kinase inhibitors, as was presented in the Summit trial, as well as HER2 antibody-drug conjugates are being explored in that space and showing some promising activity. And then another small subgroup, and maybe not this patient, but some, again, germline BRCA2 mutations, again, another small group of patients for whom there is growing evidence that there is some intrinsic endocrine resistance there. And we, of course, do have options. And so did this patient have germline testing to be sure that that's not a PARP inhibitor isn't an option. But there are increasingly these small subsets of patients, high tumor mutation burden being another one. And so I just want to point that one out.
Absolutely. So I wanted to just save just a little bit of time here at the end to discuss a few things. And Surat, you touched on one of the things I actually wanted to discuss was the antibody-drug conjugates. Aditya, I know that you've done a lot of work with the antibody-drug conjugates as well, but particularly for that population that maybe isn't really benefiting from endocrine therapy anymore, functionally we're treating them very similar to triple negatives. And we know in this setting that single-agent chemotherapy is not giving huge benefits. How do you see the antibody drug conjugates fitting in here, Aditya, and which ones are you looking forward to in the pike?
Yeah, you stole words out of my mouth. I was going to say the same thing, that biologically over time, ER-positive tumors functionally become ER-negative. So agents that work in the triple-negative breast cancer setting would work. And we use chemotherapy that's used in triple-negative breast cancer, be it taxanes or capecitabine or eribulin in this setting. So there is interest in antibody drug conjugates for these endocrine resistant tumors in the later line setting. There are two in particular that I would highlight. The first being TROP2 ADCs, which is an antigen that's overexpressed in both ER-positive disease as well as triple-negative breast cancer. And we have an FDA-approved agent, sacituzumab govitecan, for triple-negative breast cancer. The phase 3 trial evaluating this agent for ER-positive breast cancer has completed enrollment. So over the next few months, we should be seeing the top-line results. And a similar TROP2 antibody-drug conjugate is datopotamab deruxtecan. Very long name. These antibody-drug conjugates have long names. Also called Dato-DXd, which is slightly different from sacituzumab govitecan, both in terms of payload as well as the linker. The other class of ADCs are HER2-directed ADCs. Traditionally, we've considered HER2-positive breast cancer as tumors that amplify HER2 in terms of the HER2 gene. But even tumors that do not have HER2 gene amplification, that have some expression of HER2, like IHC 1+2+, potentially could be targets with antibody-drug conjugates, because for an antibody-drug conjugate, all you need is expression of the protein to allow delivery of the payload. So there's interest in HER2 antibody-drug conjugates for these so-called HER2-low ER-positive breast cancers. Trastuzumab deruxtecan being the front runner in this setting, but there are other ADCs as well that target HER2 and have some bystander effect. So I think we're going to see more and more of ADC development in this space as well.
Thanks, Aditya. I think that's really helpful. Surat, I may direct a question back to you a bit. How do you make the decision based on clinical or pathological features, et cetera, who, post-AI CDK4/6 you want to continue with endocrine therapy or even in the third line versus who you think may be resistant and needs to switch to a different class of agents?
Yeah, it's such a clinical dilemma, I think. I mean, we all struggle with these decisions. Should we give another shot at one of these endocrine agents that we know is available either as a trial or standard of care, or should we switch to something that's more chemotherapy-like? And while our patients and we want to give always the least toxic, greatest benefit kind of therapy, we also want something that works. And so we tend to go with our clinical intuition a lot in terms of, was this progressing rapidly? Was this progressing in visceral sites? Can we sort of get a leg up on the cancer before revisiting something like endocrine therapy? There are some growing sort of features that we can also use, such as what you and Aditya alluded to with low ER expression, potentially even if you had intrinsic subtyping, whether this was a basal-like subtype. These are features that are telling us something that we're probably seeing clinically, either in the scans or in the biology in other ways, and just the way it progressed. So we're using a lot of the information, but we don't have necessarily a quantitative way of saying, who should be bin to what.
So I'm going to ask one more question, kind of open to both of you. One of our big problems in the adjuvant setting really is adherence to endocrine therapy, and that's for a lot of patients because it's not very well tolerated, whether it's the arthralgias or sexual side effects, etc. Knowing what you know from the oral SERDs now, do you see a role in the adjuvant setting? Do you think that they are going to have better tolerability without the arthralgias, etc.? Do you think the GI issues are going to be a problem in the adjuvant setting? Try to predict the future for me here.
And it's funny you say that. There's actually a trial, AMIRA-06, that's looking at this exact question. Amcenestrant appears to be better tolerated and does not have the side effect of arthralgias. So it'll evaluate this oral SERD in patients who discontinue adjuvant AIs because of side effects to see if there would be benefit in that setting. So I agree. I think these SERDs have a different AE profile, particularly related to arthralgias. So in patients who have difficulty tolerating AIs, might be another option for that patient if validated in clinical trials.
Yeah, Surat, what do you think?
Yeah, I agree. I think that we have to remember that we're often asking our patients to blindly take therapy that we don't know that they actually even need. And so it's easy to sort of think, do I really need this last 2 years when I don't even know that there's any cancer there? And I'm dealing with a daily side effect that's impairing my life, and that counts. And so there are some side effects, as you guys allude to. I would also mention there may be differentials in terms of the degree to which some of these cause vaginal dryness and sexual side effects, and that may be really a powerful way in which some of these agents can discriminate and may be superior. So,
great. I think that's a perfect spot to end on. So on behalf of PeerView, thank you for joining us to talk about ER-positive metastatic disease and some of these novel agents. And I certainly thank Aditya and Surat for joining me. Thank you so much.
Thank you, Erica.
Thank you.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, PeerView Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/HCA860. This activity is supported by educational grants from AZI Incorporated, Sanofi Genzyme, and Stemline, a Menarini Group company.